Good evening, everyone, and welcome to our webinar tonight, all about vertigo. So excited that all of you could join us for this really interesting and important webinar. And no matter where you are in Canada, I hope you're having a wonderful evening. And I think we might be having a couple people from the United States join us too, so I hope they're having a wonderful evening as well, wherever you are. So before we get started in terms of introducing our speaker today, Blair Graham, we're going to go through a few things. So first off is that our webinar today is going to be recorded. And in about 2 to 3 weeks, it will be on our YouTube channel and our website. And we'll also send links out through our social media. There'll be a presentation tonight. It'll be about 1 hour in duration in total, and that includes a really great opportunity for Q&As after the end of the presentation. And because we're recording it, we ask that any questions are very broad in nature and not talking about your personal medical situation. We really want to make sure we're protecting your privacy, and also the forum doesn't really allow for personal medical advice. So if you do happen to put something in a question, I'll probably edit it before it gets asked to Blair. If you do have any questions, at the bottom of your screen, if you take a look right now, there's a little spot that says Q&A. Please make sure you put your question there instead of in the chat window. In the chat window, I won't be looking for questions. So the best place to put them is in the Q&A. And when we get to the end of the presentation, we'll be sure to take a moment in order to ask your question. And so with that, I'm going to go ahead and introduce our speaker for today. So I'm really pleased to have Blair Graham joining us today. And Blair has a physical therapy degree from University of Alberta. He has a certification in advanced orthopedic manual and manipulative physiotherapy through the Canadian Physiotherapy Association. He also has certification in advanced vestibular rehabilitation through the American Physical Therapy Association in partnership with Duke University. He's also a member of the Canadian Physiotherapy Association. Currently, his practice is at Level Up Physical Therapy in Edmonton, Alberta, Canada, which is focused and dedicated to people with vertigo, dizziness, and balance problems, as well as those recovering from concussion. And so now that we have introduced our speaker for today, I'm going to go ahead and hand it over to Blair. Welcome, Blair. We're really, really thrilled to have you here with us today, and we're looking forward to your presentation.
Thank you, Prem. It's a pleasure to be here. I'm glad you guys asked me to do a presentation on something I'm really passionate about.
Thank you.
We'll start our presentation on vertigo. We will. One moment here. Share a screen. Well.
So anyone who's just joined the last few minutes, welcome and thank you so much for attending. And go ahead, Blair, when you've got your presentation ready to go. And everyone, while you're waiting for our presentation to start, you can go ahead and get thinking about vertigo and all about the questions that you might like to ask at the end of the presentation.
My apologies here. This was working.
That's okay. This is technical stuff that we deal with all the time. So when we have different webinars and meetings going on. So.
And is that working now?
Looking very good. Go ahead.
Yeah. Okay. Vertigo. So a good question to begin is, what is it? A lot of people have heard of the word before, but it's really the experience of motion when none really exists. And it could be really any direction. It could be spinning or swaying side to side or bouncing or rocking, all these things. But it can come from a number of different places. It could be from your inner ear, it could be from the nerve that connects to your inner ear and connects that to your brain, or it could actually be in the brain itself. So we should look at maybe the inner ear firstly, and understanding a little bit of anatomy. There's not an exam at the end. We have this is our inner ear. From the outside, sound would come into your ear and vibrate our little eardrum, and that would allow you to hear. But the area that we're talking about is a little bit different. This curly side is for the hearing, but these little loops, which are called semicircular canals, these are the part of the inner ear that that will cause vertigo. This little section here, where they connect, is also part of the sensor mechanism within the ear. And this whole thing is called the vestibular apparatus, and it is for sensing head motion and head position. From above, just to orient yourselves, we can see again these semicircular canals or these loops in the inner ear and the nerve coming from that area and heading off to the brain. Those semicircular canals do sense head motion and send that information to your eye muscles. And the reason for that is to keep your eyes steady in the world as your head is moving around. And this is the only reason why you can walk and read, or even sit still and read. If both inner ears don't work at all, then even your heartbeat will make your vision jiggle. So if you turn your head to the left, your eyes will move to the right. And it doesn't matter what direction or how quickly you move your head, your eyes will actually stay still in space if your inner ear system is working properly. But if you're getting abnormal information about your head motion coming from the inner ear, that can cause your eyes to jump around repeatedly in one direction. And that little jump is called nystagmus. And if your eyes are jumping around like that, you might experience some visual sensation of the world jumping or spinning. And that's where sometimes someone might ask you, well, does it feel like you're spinning, or does it look like the world is spinning? The truth is you can feel both at the same time, depending on whether your eyes are open or closed. The other area that can cause vertigo is from the nerve that connects your inner ear to your brain. The inner ear has these two nerve bundles coming from the hearing side and the vestibular side, and those signals are sent off to the brain stem. And you can also experience vertigo from the brain itself. All these nerves that go to your brain, any of those sections that those nerves go to can cause vertigo. Two important parts of the brain that can cause vertigo are the brain stem and the cerebellum. If we look at our brain, this part here is the brain stem, and this part over there is the cerebellum. And we put a little eyeball there just to orient yourself to where this stuff might be. And in this picture, you can sort of see the cerebellum is sort of the back lower part inside the skull. You can look around the brain a little bit. This is the front and the right side and the rear and the left side. Now, you understand some of the anatomy of those three areas that can cause vertigo. So we should talk a little bit about vertigo. So it could be the inner ear or the nerve that connects the inner ear to the brain, or anywhere in the brain that those nerves connect to. So the most common inner ear cause of vertigo is something called BPPV. That is shortened because It's benign paroxysmal positional vertigo, which is a mouthful. What in the world does that mean? That means benign is not medically dangerous. Paroxysmal is bursts. Positional because the symptoms are triggered by head positions. And vertigo because usually there's a spinning sensation with it. What would you experience if you had BPPV? Well, often the initial incident is with a roll in bed or when you're first getting up out of bed. At that moment, you might feel a strong spinning sensation, and if you stand up too quickly, probably imbalance. But the worst of that experience is typically over in less than a minute. So it's not long lasting, the severe part. You might not feel great afterward, and that's okay, but the worst of it is over in less than a minute and often less than 30 seconds. Unfortunately, with any spinning sensations, sometimes there is nausea, and some people do vomit. Some key points about BPPV is that head position changes with respect to gravity provoke brief attacks of vertigo. So you actually have to change your head position, moving from a sitting position to a lying position, for instance, to trigger that attack of vertigo. Some short statistics about resolution of BPPV. 20% resolve without any intervention within the first month, 50% within the first 3 months, but then you have 50% of people that have daily episodes of vertigo for more than 3 months. You want to sort of understand it a little bit better. Excuse me. This is our inner ear. These are the loops or semicircular canals that are important for with BPPV. If we oversimplify the anatomy, there's sand-like material attached to a jelly-like pad in your ear. That sand-like material is made of calcium carbonate, and it's supposed to be there because if you tilt your head, then the weight of that sand helps to shift that little jelly pad around very slightly. But that's enough to give you information about your head position. Here is a semicircular canal, and that loop is filled with fluid along with the chamber where that sand-like material is. And then down at the bottom, there is a little sensor, and that sensor senses the movement of the fluid in the loop. Sometimes, though, some of that sand-like material might be in the loop. If it's in the loop and staying still, it's not a big deal. You don't really feel too badly. If you change your head position, that stuff's going to fall through the loop because gravity will move it, but that moves the fluid, which flips the sensor, and then you feel lucky. So that's one type of vertigo related to the inner ear is BPPV. What we would do for assessment is test a bunch of head positions. Ideally, you'd use an infrared video camera with blackout goggles over their eyes to most clearly identify the direction of eye motion. This is helpful because it helps identify the ear and the specific loop that's affected. If you can identify that loop specifically, then your treatment's going to be more effective and efficient. A set of goggles that would do that is something like this, where the camera is on over the right eye, and then we can close the left eye. That eye movement we're watching for could look something like this. See, it's jumping to the right, and that jumping to the right, that's temporary, means there's probably something going on within one of those loops. The treatment is basically to use a series of head positions which allows gravity to move that material in the loop all the way around from the closed end of the loop around to the open end, and then drop it back into the chamber. Once it's in the chamber, then it can recycle. Usually, if you can identify the loop or the semicircular canal that's affected and use the right maneuver, 90% of people will be better within 3 sessions. There's always 10% of people that make life difficult, but usually we can help those people as well, although maybe it takes 4, 5, or 6 sessions. Now, the nerve that connects to the inner ear that we're worried about is the vestibular nerve, and that can also cause vertigo. So that nerve, usually it's going to be something that squishes the nerve that causes a problem, but there are conditions where the nerve can spontaneously cause electrical signals, and then that was also experienced as vertigo. So one example of a vestibular nerve problem is a neuritis, and that's an inflammation of the nerve, but that's because the body's fighting off what we think is probably a viral infection in the nerve. But that, excuse me, that reaction causes swelling. The nerve travels through a really narrow bony tunnel to get to the brain, but there isn't really much room for that swelling. And with that extra swelling, the nerve becomes squished, and then that blocks information coming from that inner ear. When you have that asymmetry where one inner ear is telling you something different than the other inner ear, then that's going to set up the sense of vertigo, and again, feeling awful. If this was the case for your vertigo, then often the initial onset, you start feeling kind of not right through the day, and then people often will describe it feeling like they might have some flu-like symptoms. But then over a few hours, it's going to progress into a strong spinning sensation that is continuous. People end up finding a position lying down that feels the best, but it doesn't really resolve the vertigo. It just is the one best position for them. Any head movements while you have this problem is going to provoke more dizziness. You'll also develop unsteadiness with walking, but usually you don't need any assistance to walk. So if a person needs a lot of assistance to walk, we start to wonder if it's actually a nerve problem or if it's more related to the brain. So the common symptoms: continuous vertigo, head motion intolerance, unsteadiness when you're standing or walking, and then the upset stomach and vomiting. So the treatment and management of that condition, sometimes there's medications. Certainly there's a rest for the first 2 or 3 days because any head motion just feels completely horrible. But then once the inflammation around the nerve settles down, usually you want to start a program of exercises called vestibular rehabilitation. And the earliest you should start that is day 4. You can start it later as well, but usually earlier means you get to maximize the speed of your symptom improvement, the speed of functional recovery, and it allows you to achieve the highest level of return to activity. The brainstem and cerebellum as a source of vertigo. Recall that that's that area in your brain, deep down inside. The big concern here is related to stroke. This could be a bleeding stroke where a vessel ruptures, or it can be a blood clot that blocks the blood supply. Both result in loss of blood supply to an area in the brain, and that can cause symptoms of vertigo. This is important in cavernous malformation because the bleeding that can happen mimics stroke symptoms. Again, feeling awful. Now, the symptoms related to stroke will often be due to that brainstem or cerebellum involvement. It'll often have a rapid onset, and it'll often involve more than one structure in the brain, and that means that you'll feel more than vertigo. You'll feel numbness, tingling, weakness, double vision, something else, quite commonly. There are rare situations where it can be isolated vertigo, and then it takes a little bit more investigation to sort that out. So symptoms that you might feel if there's bleeding or a clot in the brain. This could be difficulty with articulation with words. So this is in association with the vertigo. So I have vertigo and I'm having difficulty speaking in some way. This is concerning. This should be off to the hospital. Your vision might seem continuously jumpy. You might have severe imbalance and unable to stand without assistance. You might have incoordination of your limbs or body. You might not be able to sit upright without assistance. There might be numbness or tingling in your face or limbs. You might have weakness. You might have new hearing loss on one side, or you might even have double vision. Any of these connected with vertigo should really be taken seriously and should be investigated in the hospital setting in the emergency department. It's important to understand that this type of vertigo is continuous. It's not just sort of on and off, 5 seconds here, 1 minute there. So it's important that we understand and differentiate between intermittent vertigo and continuous vertigo. For intermittent vertigo, is it provoked by head position change? For example, moving from sitting to lying or lying to sitting? Does it happen when you roll in bed? Does it happen when you tilt your head backward? Does it happen when you bend forward to reach to the floor? Does it last less than 1 minute? If this is the case, probably your doctor is not going to be too worried. This is highly suggestive of BPPV and is not medically worrisome. Continuous vertigo, though, that's worse with head motion, feels worse with head motion, but there may be even some positions that cause you to feel worse, and then other positions that make you feel a bit better. You'll have continuous unsteadiness, but again, vertigo with any other symptoms, including hearing loss, immediately raise a flag of concern for everyone involved in your assessment, and this is medically worrisome. It doesn't mean that it's something serious, and it probably isn't, but further testing and evaluation is needed. Realize that vertigo can be complicated. We've talked about isolated symptoms or conditions related to the brain and the inner ear and the inner ear, sort of the nerve to the inner ear and the inner ear. But we can have inner ear problems that are similar to nerve-related problems, or nerve-related problems that are similar to inner ear-related problems. We can have nerve-related problems that are similar to brain problems, and brain-related problems that are similar to nerve-related problems. This is sort of the important differentiating side of the triangle that is the focus of the emergency department. So there's lots of, the emergency doctor needs to really make sure that when they send people home, that it's related to the nerve of the inner ear, not the brain, because you don't want to miss a stroke and tell them, oh, don't worry about it, you're going to be fine. The other side is brain-related problems that present similar to inner ear problems, or inner ear problems that present with brain-related problems. So it can become more complicated as you dig deeper and deeper into the subject. Now, there are some reported cases in the medical literature about cavernous malformation causing vertigo, but you'll notice some things when we go over these two cases that should raise your eyebrows a little bit. So there's a 13-year-old boy, onset of dizziness and vomiting 1 week ago, and diagnosed with acute gastroenteritis, so a stomach bug. But the symptoms persisted after the treatment of that. Then there was a sudden onset of severe dizziness along with double vision. Double vision usually is not a good sign. They went to the emergency department. The boy denied spinning type vertigo and denied any headache. The physical examination showed gait disturbance, so unsteadiness. Eyes were jumping to the right. Those two aspects are not concerning, but the double vision that was noted is. So they did neuroimaging and they found that it was a cavernous malformation in the brain that was a source of his symptoms. Lastly, we have a 20-year-old woman who's had vertigo for 1 month with vomiting. Now, initially, she was assessed at a neurology clinic and treated with medication. To me, that means that whoever saw her suspected that this was an inner ear or nerve-related problem. But the symptoms did not improve, but she also did not return to the neurology clinic for further investigation. Usually, if you leave a medical appointment and the physician thinks that you have vertigo related to an inner ear problem or a nerve related problem, they'll always say that if you're not getting better or if you're feeling worse in any way, please come back. We need to reassess. Now, for her, double vision did develop, but apparently that was not enough for her to return for further medical evaluation. And then after 2 weeks, she found that her right side of her body, her arm and leg, were becoming weak, and she had a headache at the back of the head. She did not return for medical evaluation at that point until 2 weeks later. Now, in physical examination, when they test the eye movements, the right eye does not move properly to the right, and the left eye does not move properly to the left. When she looks to the left, her eyes are jumping to the left. And when she looks to the right, her eyes are jumping to the right. That's nystagmus. Her eyes are also jumping vertically repeatedly. Again, upward beating nystagmus. Well, they don't say if it's up or down, but vertically is not a good sign. And then there was right-sided weakness noted with strength testing. Now they ordered an MRI, and this was cavernous malformation in the cerebellum that we talked about. So if the thing about these two cases is that if you do develop vertigo that's continuous, and even if you've seen a physician and they say, "Oh, don't worry about it," it seems like vertigo. Usually they mean inner ear related vertigo, and something's not. If it's not improving after a couple days, or things start getting worse, as in you develop new symptoms, go back and tell someone, go to the emergency department, explain the situation. If you know you have this diagnosis, then explain that to them, and they should be taking this seriously. Now, sometimes the management is observation, but it's important to get the right diagnosis. Thank you. If there's any questions, we can answer questions too.
Thank you so much, Blair. That was really, really informative. If you want to take yourself off share, and we'll go ahead
Oh, yeah.
and take a question or two or four or five. And yeah, I really appreciated your presentation. So here's our first question. Is it
Mhm.
true that once you've experienced vertigo, you're more susceptible to experiencing it again?
Hmm. This is mostly true. depending on the cause. So for instance, okay, if you have BPPV, that's that positional vertigo, 50% of people will have a recurrence sometime in the next 10 years. So there's a good likelihood that you're probably going to have that come back again. But we don't have a way to predict who that person's going to be, how long it's going to be before their next episode. There's not a blood test or any checklist that we can do. There's no predictive measure for that. Um, Once you've had it a second time, then we can probably assume that you're going to have it a third and a fourth and a fifth time sometime down the road. Now, a nerve-related problem, so if you've had a vestibular neuritis and that nerve has been swollen and recovered and your body is healed, there's only a 2% chance that that would happen again. So 98% chance that doesn't happen. So it does depend on the specific cause of the vertigo. Yeah.
Okay, great. Well, thank you so much for that one. Um, okay, so we have another question, and that question is, are there things we can do to reduce the likelihood of certain types of vertigo? For
hmm
example, to prevent the sand from moving around
hmm
in your ear?
Yeah, so there has been some research on this. The research is more specifically to people that have a very recurrent type of benign paroxysmal positional vertigo, BPPV. The positional vertigo, they might be getting a recurrence every week or every 2 weeks, and just you treat it, it goes away, and it comes back, and it comes back, and it comes back, and it comes back. The research has looked at blood tests, and they've looked at their vitamin D levels. And for those people that have a very recurrent type of positional vertigo, it appears that a lot of these people are low on vitamin D. And when they supplement them sufficiently to get their vitamin D levels into normal range, then the frequency of recurrence of BPPV reduces a lot. Doesn't go away completely. So this is something that everyone should be talking to their doctor about. Living in Canada or even the northern US is, a lot of times we don't have sun exposure on our skin, which would be a way for our body to make vitamin D. So we need a supplement. But how much should that supplement be? Should it be different in the summer compared to winter? Maybe, but this is something that you can talk to your doctor. Some places might offer a blood test to let you know, hey, your vitamin D levels are low. But probably the best time to get that blood test is sometime in the winter months, in the northern hemisphere here, and maybe in December or January, because at the end of August, if you spent a lot of time outside, your blood levels of vitamin D are probably going to be normal.
Yeah, that's a great point.
Some
That's a good
types of
point.
vertigo, there are some food restrictions that can be helpful. So some people should be on a low salt diet, or at least try a low salt diet. Migraine can also cause vertigo. So that would be a brain related problem, but not a dangerous brain related problem. And for those people, they may find that they have common triggers for migraine, which might be poor sleep, dehydration, skipping meals, um, blood sugar levels going too high, too low. They might find that stress provokes their vertigo if it's migraine related. And some people are sensitive to certain foods like caffeine and chocolate and alcohol. And then there's even some people that are sensitive to other things, which might be like bananas or peanut butter or yogurt, things that you think are healthy, and cheese. But for some people, that might provoke their vertigo. So it all really depends in terms of prevention, what type of vertigo we're talking about. But there can be things that you can do to prevent these things from coming back once you isolate the exact cause for yourself.
Okay, great. No, thank you so much. That's really interesting information. Is the sand that you referred to in the ear also called crystals?
Yeah. So it's a salt material of calcium carbonate. And some people call them crystals, and they are. Under a scanning electron microscope, they look like crystals, just
Oh,
like a salt crystal from your table salt would look like. But it's dust is really what it is. I call it sand because usually it's not one crystal. One crystal might be even the size of a red blood cell, which is not going to cause symptoms. So you got a clump of this stuff moving through that loop or semicircular canal. And it is what people often refer to as crystals. Unfortunately, the internet of people trying to align your crystals in your head to fix your vertigo. And so it just kind of, I avoid the term crystals, but yes, because it sounds like there's one giant kind of crystal of something in my head that's off kilter, but it's a dust-like substance.
okay,
Yeah,
great. No,
so
that's really
crystals is
cool.
correct, sand is correct, calcium carbonate is correct.
Okay, great. Okay, great. Awesome. That's good to know. Is it harder to treat vertigo if you wait too long to treat it?
Hmm. Again, I'm going through the different causes. If you wait too long, so for benign paroxysmal positional vertigo or BPPV, sometimes it can be more difficult to treat if you leave it too long. The reasons for that are the little sensor in that loop that moves with the fluid. Sometimes that sand-like material can get stuck to the sensor if it's been sitting there for too long. And then you can't just tilt the head in different positions to remove the material because it's not free floating.
Mm.
You actually have to shake that sensor to knock it off. So that can make it more difficult. Sometimes, sometimes that can happen even if you're not waiting too long. Other conditions of vertigo, something like migraine, or even nerve-related problem, or maybe something related to the inner ear, like Meniere's disease. These things can cause the uh, the brain to be maladapted during the recovery period. So its preference is to stay completely still, move less and less and less to prevent symptoms. But even though it's a great short-term strategy, as a long-term strategy, it doesn't work out very well at all. And so people can become more and more and more sensitive to head movement and head positions because of the way they've tried to adapt to the condition. And so then it can become more difficult to treat. So usually the earlier we can get on things, the better. Um, yeah.
Okay, very good. Very good. Is there any truth to the idea that Chinooks or other weather phenomena increase risk of vertigo? And the person says that they're guessing the
Yeah. It's a mouthful
BPB
even just doing the
type. It
letters.
is. I
Yeah.
apologize.
So just say, yes, you just say positional vertigo. It's okay. Um, Probably not for BPPV, although I don't know of any uh, good evidence that it does or doesn't. There does seem to be more episodes of vertigo with weather changes, but one big consideration is if migraine is causing your vertigo. And migraine can be headache free. So commonly people might be experiencing migraine as, oh, I have a visual aura of, oh, zigzag lines or speckles or sparkles or something. And then 10 or 15 minutes later, their headache. But you can also get that visual aura without any headache. And so often it's termed, um, headache-free migraine or something similar. Yeah, we don't have to get into the exact terminology, but you don't need a headache necessarily. But that neurological symptom of visual aura could also be a vestibular aura. And so you can get vertigo. And some people are with migraine are sensitive to abrupt weather changes. So people living in Calgary with the Chinooks, you might find that you get more episodes of vertigo, especially if it's migraine. The frustrating thing about migraine is that it can also present as positional vertigo. So you do a position test and it triggers vertigo. That's why you need a camera to watch what direction the eye is moving to make sure that it matches what should show up in that position if it's related to one of those little loops in the inner ear. So Chinooks, weather changes can trigger vertigo, especially if it's migraine related. And then other conditions may be less sensitive to migraine or to weather changes.
Okay. Okay. Awesome. Thank you so much for that. Um, will vertigo always occur if you have a stroke, which affects the brainstem or cerebellum? Do you know?
It's not necessarily. So in the cerebellum, it would have to be closer to the center. If it's further out to the edge of the cerebellum, then you're more likely to have incoordination of your arms and legs. Um, as it gets closer to the center, this is where the inner ear connections to the cerebellum are located. And in the brainstem, um, it all depends on where in the brainstem. So the brainstem has the top level is sort of where the nerves from your eye muscles are. And then as you move down through the brainstem in the middle area is going to be where the vestibular inner ear information is located. And then below that starts to become more related to your tongue and swallowing and shoulder strength. So it really depends on where in the brainstem there's a problem.
Okay. Yeah, that's really good to know. That's really good to know. So I've got a couple of questions kind of regarding balance. If
Hmm.
you don't mind talking about that. So one of them
Yeah,
is
of course.
how do vision issues affect balance?
Hmm. So yeah, our balance is we usually use three different mechanisms to maintain your balance in all different situations. One is your vision, because you use your vision to orient yourself to the world, whether I'm vertical or horizontal or where I'm moving in the world. The inner ear tells you about your head position and head movement. And then you use information, let's say from your feet. Is my weight shifting a little to my left onto the pinky toe, or is it shifting toward my toes on both feet? And that'll give you information about your balance as well. And so vision problems can cause um, or be involved in balance problems, especially if you have developed double vision on and off. Some people when they wear glasses, like bifocal glasses, the reading portion being on the lower part of the lens, that can cause some problems because people look down and the world doesn't look right. And so they're getting a weird visual information, but the other parts of their system are telling them the correct information. And in that moment, the brain is going to be a little bit confused. Oh, wait, how close is this thing? Like, where is my foot in relation to the curb? And that, so vision problems can cause imbalance. The other situation is if you have low vision plus another problem. So if you have an inner ear problem, or a sensation problem in your feet, then your low vision and impaired information from the other senses is going to cause imbalance. So those
Okay,
are two
wow.
situations where vision could definitely influence your balance.
That's great. Thank you so much for explaining that. Is there any exercises that a person can do to improve their balance?
Yeah, so depending on what is causing your balance problem, there are lots of different exercises. Commonly, you'll see people say, well, just balance on one foot, and that could be helpful. But it depends on where your balance problem shows up. Does it show up when you're standing still? Or does it show up when you're in the dark? Or does it show up when you're moving around? Does it happen when you bend forward and reach to the floor? Or does it happen every time you turn to the left? So trying to understand when the imbalance is happening helps develop the exercise program. And for some things, there's a lot of exercises. And so for other conditions, there's maybe not as many, but still probably worthwhile trying. So exercises do improve balance, but again, we have to figure out, rather than being a generic, oh, just do some balance exercises, you should be really specific as to what you're targeting.
And would you say the best way to do that is actually to have like an assessment or evaluation with a specialist, like
Yeah,
a vestibular specialist?
you probably want someone with a vestibular rehabilitation background, to really sort out the difficulties that you have with your balance, because it can be an inner ear problem that's causing balance, and that changes the dynamics of the exercise program that we recommend.
Okay, great. I think we have time for a couple of more questions, but in the
Mhm.
meantime, we're getting some thank yous for you.
Oh,
And also just somebody
my
who said not
pleasure.
a question, just want to thank you for the presentation, very informative. And we'll take a couple of minutes if anybody else has a couple of questions, because we do have a couple of more, but I think we might have room for 4 or 5 more. Okay, so I do have a little bit of a scenario
Oh, good.
that somebody has presented. And I know you talked a lot about this in your presentation, so that might be helpful. But
Hmm.
if you have any other thoughts, kind of thing. So if somebody had kind of like that vertigo that was temporary, kind of thing,
Hmm.
and um, and then several hours later, they experienced vertigo again with accompanying like nausea, but not able to really do it, not able to have any vomiting kind of thing. And they end up going to a hospital because, lots of times, those of us with cavernous malformation, we know that if we have symptom changes, we probably should be seen in an ER or that kind of thing, especially, we're always kind of worried about having the hemorrhage or bleeding kind of thing. A few days later, like they had the maneuver, the Epley maneuver, is that what that maneuver is called?
Hmm.
And it resolved the vertigo they were having. And a short time later, there was an MRI done that showed there had been a bleed. Is there any thoughts do you have about whether that vertigo that had taken place, could have been indicative that there might have been a hemorrhage going on?
Hmm. If it's on and off and not progressively getting worse and worse, probably unlikely to be something related to the brain. You are allowed to have more than one problem at the same time. And because BPPV is it's the most common inner ear cause of vertigo, you can have that along with other things.
Yeah.
So if it was on and off, and the Epley maneuver, which is one of the maneuvers for one of the semicircular canals to clear it out, if that was successful in resolving the symptoms, then it's quite likely that the person did have a positional vertigo, but then also has something else.
Okay. Okay. Now
Yeah.
it's good to know, because I think sometimes those of us with cavernous malformation, it's hard to partial out sometimes. Like,
Hmm.
I know sometimes we think a lot of our symptoms, well, this must be related to my cavernous malformation or malformations,
Hmm.
when maybe it's something that could be treated in a different way and at least improve our quality of life and help us kind of thing.
Hmm.
So thank you so much for that. So awesome information. So if somebody is experiencing vertigo and not other symptoms with it, like you talked about, like
Hmm.
not having double vision or
Right.
other
Yeah, definitely
symptoms.
those two case studies. If you get double vision, please
Yes, please
go
go to
get
the
checked out.
ER.
Yeah.
Don't call and book an appointment, with a
Yeah.
vestibular rehabilitation specialist. Go
Right.
get that checked out first. That's immediate kind of thing, especially with other symptoms. But if it's not one of those situations,
Hmm.
what kind of treatment is available for the
Yeah. Yeah.
other stuff? Yeah.
Right. Yeah. So for a positional vertigo, we really want to identify which of those loops or semicircular canals are affected, and in what way. Is it free floating debris or stuff that's stuck to the sensor? Is it just one loop, or is it more than one? Or is it both ears? So these are questions we need to answer. Once you answer those questions, you can use head maneuvers to treat that particular type of vertigo. Um, if it's related to the nerve, like a neuritis that we talked about, Then as soon as the inflammation starts to settle, which is usually by day 4, things are not so severe anymore. Then we use exercises to help the brain readapt to the way the nerve is behaving, because it is a nerve injury. And sometimes the nerve will come back up to full function, but sometimes it might only come to a partial function. So let's say it's 80%. If that's the case, then you're always going to have different information from one ear compared to the other. But you need specific exercises that allow your brain to compare that information. Oh, this is what the right ear is telling me. This is what the left ear is telling me. Well, that doesn't make sense. But working on the exercises, you can teach the brain, okay, well, if that's the case, then it actually means this. It doesn't mean I'm tipping over to the right. It actually means I'm straight. And then you learn how to reprocess that information coming from that inner ear. And so there are um, head movement exercises and balance type exercises to be working on to help the brain reorient itself. In terms of other conditions, some things you could introduce exercise for, but other things, the exercises are not helpful. Migraine is sort of in between, usually a very careful exercise program that's initiated and progressed very slowly can be helpful, allowing the brain some more time to figure out what this information means. Because often people with that vertigo type migraine are also very, very sensitive to head motions and sometimes visual environment, movement in their visual environment. And so a very slow and cautious exercise program can be beneficial for those people. Other conditions, exercise is not helpful. So really defining the cause of your condition is super important.
That's what it sounds like. So key thing is that the takeaway would be that yes, there is many treatments available depending on the cause. If I get this right, Blair,
Yeah,
the key thing is to being assessed and evaluated by somebody
yeah,
who is has a specialty in vestibular rehabilitation, correct?
yeah, yeah.
And so how do they find these people?
Right. So someone like me, you can, in Canada anyway, there is a website called Balance and Dizziness Canada. And on that website, there are people that are registered practitioners, and they are required to have a certain level of education. So there are some websites where basically if you pay your money, you're on the site
Yeah.
and you're registered. For this in Canada, Balance and Dizziness Canada, um, they vet who can be on that website based on the courses that they've taken. And so there's only 3 or 4 accreditation courses that you have to, and these are multiple day courses. So usually 4 or 5 day courses that are required in order to be allowed to register on there. It doesn't mean that everybody is registered there because it is, you have to pay for your registration, but it's really the simplest way to find someone in your area. And if there's someone just in the same province, maybe phone that clinic and see if they would know anyone in your area. Because there's, for me, I can look on a website and try to figure out, okay, what background does this therapist have, and do they have kind of what I would consider, a higher level education, or is it, unfortunately, some people have like, just a 1 day course or a half-day course or a 2 day course where it's really good for introductory level education, but not sufficient to deal with that whole triangle that I highlighted. Because you can be good at certain things, but then if you're looking at that whole triangle as possibility, it can be complicated. So
No, that
dizziness, or sorry, Balance and Dizziness Canada is really a good website to check out.
and I'll make sure everyone who has registered for our webinar tonight, I will email that link to everyone so that you have it. I think that's really important information. I forgot to mention too in your bio that Blair is actually with Level Up Physical Therapy in Edmonton, Alberta. That's where he's based out of. So he is based in Canada. And yeah, thank you so much for that, to make sure that, like if we're not experienced at looking at all the education and stuff in the bios, that we at least having somewhere that we can go that know that they have done the education appropriately and are on a listing, because of the fact that they have the correct credentials for this type of thing is really important. So I can't thank you enough, Blair. Your presentation was incredibly thorough and very, very helpful. I know it's really helpful to me as well. And so thank you so much, everyone. Thank you so much for attending tonight. So wonderful to have you. And thank you so much for your questions. They brought out such a great degree of information. Again, you'll see our this webinar again posted in the next 2 to 3 weeks. And I hope you have a great rest of your evening. And thank you so much, Blair, for your time to give to
Oh,
us
thank
tonight to
you for
talk to
having
us
me
about
here,
this.
Prem. Thank you.
You're so welcome. You're so welcome. Thank you so much, everyone, and have a good evening.
Cool.